to this live virtual workshop on scars management. This afternoon, we have two speakers, Dr. Pedro Santos. He's an aesthetic doctor from Portugal. He's very young, but he is very experienced. He has a lot of experience in laser and energy-based devices. And well, he also is a teacher at the university, and he runs several masters on aesthetic medicine. Our second speaker will be Dr. Didac Barco. He's a very well-known dermatologist in Barcelona. He's also very young, but again, with a lot of experience in energy-based devices. So now I give the word to Dr. Pedro Santos, who is going to be our first speaker.
Everyone, thank you, Patricia, for the invitation and for the presentation. So we're going to talk a little bit about scar treatments on a science-based view. I think we all understand that in 15 minutes of review, we can't cover everything, but I'll try to give you like a panorama of the scar formation and the physiopathological ways of modulating this scar formation for us to be able to set up a science-based protocol too. Next slide, please. So we have like super fresh evidence published this year already, an international consensus of laser treatment of traumatic scars that I will be using to base my presentation. Next slide, please. So after wounding, we have 4 phases of healing, four main phases of healing. We start on an initial phase of hemostasis, and the 3 next phases are the most important for us when thinking about scar treatment. The inflammatory phase, the proliferative phase, and afterwards the remodeling phase. These phases are overlapped in time, so sometimes we are addressing not only one phase of healing when treating, but almost 2 at a time. And we have to have in mind that when we have any impairment on any of these phases, this leads to healing abnormalities and thus to scar formation with tissue alterations as atrophia or hypertrophia. Next slide, please. That is basically this. When we have an imbalance in any of these phases, we will have an alteration on tissue architecture and sometimes in function too. Next slide. We should always have in mind that on scar tissue, we have some alterations, and these alterations are not only on the architecture of collagen fibers, but also the collagen 1:3 ratio that normally it's augmented on normal and even more on hypertrophic scarring. Next slide. First question of the day, when to treat the scar? Basically, the first message that I want to give to you is the treatment should be set up as soon as you see the scar. And this leads us to 2 treatment regimens, the primary or secondary treatment. The primary treatment is basically treats the scar as soon as we see it, just after the wounding, meaning that, for instance, if you have a surgery scheduled, you can already schedule your treatment to assist your wound healing by laser treatments. Next slide. And the second message that I have to leave you is that we have to leave the diagnosis of the scar apart, because we have to treat, rather than the diagnosis, the scar features. So in a very same scar, we should assess the vascularity of all scar, meaning that we can have one part of the scar with vascular activity and other part without it. And we should know that when we have redness on the scar, this is a hallmark of scar activity and should always be treated. After that, we should assess the volume status if the scar is atrophic, hypertrophic, or a keloid. And also, and for the least, assess if we have an hypo or hyperpigmented scar. On laser-assisted wound healing, as we're programming and modulating our scar formation, we don't assess these features. We address it separately, as we are going to see next. Next slide, please. So, as we already discussed, the laser-assisted wound healing, the objectives of this is to modulate and guide the scar development. So we should start it and initiate the treatment at the day of removing sutures, because we are just on the transition of the inflammatory to the proliferative phase. There are actually some papers that already show a benefit to treat the skin previous to the surgery with mainly non-ablative fractional lasers. But nowadays the consensus still is to treat on the day of removing sutures. We should combine vascular laser with non or ablative fractional lasers, because we have a synergistic effect. Normally the treatments are 6-week interval, and normally on sequence we start with the vascular laser, and after that the non-ablative or the ablative fractional laser. Next slide. So why to use a vascular laser on scars? First of all, the reference that we have on vascular lasers on scars is the pulsatile laser, is the wavelength that we have more published science on that, and we know that it acts like a regulatory effect, because it basically inhibits DGF beta 1 and other pathways. It leads to uncollagenase, the MMP13 upregulation, and on proper dosing, as we are activating the P53, the BCL2, and the Fas ligand, we lead also to a fibroblast apoptotic response that will lead to a thickness and pliability improvement. And this is thought to be the main mechanism of action of vascular laser on scars. After that, we have another mechanism that is the photocoagulation of the microcapillary that are present on the scars. Basically, we are inducing a transient hypoxemia that leads to an VEGF release buffering effect. This action also leads to an improvement on erythema and on pruritus if it is present on this scar. Next slide. The use of ablative or non-ablative fractional lasers on scars is because we are inducing the release of the heat shock proteins, mainly the 47 and 70. That will lead to favoring the collagen type 3 production than type 1, trying to imbalance the collagen type 1 to 3 ratio on the scar, becoming the tissue more similar to a regular one, or non-wounded one. After that, as you are inducing a breakdown on the tissue by the ablation columns, this can lead to a point where we can distress the superficial and disperse the superficial tension on the scar. And we know that the superficial tension is an important feature on abnormal scarring. Also, as we are doing this epidermal impairment by the ablation, we can take advantage of these to do laser drug delivery that is mainly important on hypertrophic scarring. And as already we have discussed, we have a synergistic effect when combining with a vascular laser. We should know that these alterations, this collagen shifting that we are inducing is time dependent. We know that after a single session of ablative fractional laser, we still have changes on the tissues 6 to 9 months before after the treatment. So we have always to tell our patients that we need time to produce the needed tissue changes. We also should know that we can use non-ablative fractional lasers, but these type of lasers induce a less intense HSP expression response, normally leading to more sessions needed to achieve the same treatment result. Next slide. And we also have to acknowledge that treat a scar is a multimodality treatment, and we should combine treatments to get the best outcome. The main treatments nowadays are the laser and surgical revision, and we have several adjuvant therapies that we should combine to get those results, such as subcision, lipo or other soft tissue fillers, anti-proliferatives as potent corticosteroids and 5-FU, compression therapy, very important, botulinum toxin modulating the myofibroblast activity, superficial radiation therapy or radiotherapy directly, mainly on hypertrophic and keloid scarring, and the basics, but always important, the hydration and the sun protection, the broad sun protection of the scar to create an appropriate medium for healing and to avoid post-inflammatory hyperpigmentation. Next slide. So, basic and trying to accommodate this info to each kind of scar, we are now reviewing the treatment parameters and how to combine these two types of lasers. Next slide. Starting for the laser-assisted wound healing, on the first appointment that should be at the suture removal day, we should start with our vascular laser, ideally with the pulsatile laser on a suprapuric dosing. When we talk about suprapuric dosing, we should see on the tissue an immediate darkening, and just after that darkening, a lightening of that darkening to a mild erythema. Basically, we know that short pulses are most effective, but when using these so short pulses of 1.5 to 3 milliseconds, we should use low fluencies to induce this kind of suprapuric response. On low-risk patients, we can, on this first session, only use the vascular laser, and we assume a low-risk patient as a patient that has no previous history of abnormal scarring. When this history is present, we should consider to add at least a non-ablative fractional laser. We should always advise to use compression either on gel or eventually on silicone sheeting. hydration and broad protection factor. And the next appointment should be scheduled on 4 to 6 weeks. Why? To sometimes shorten the appointment to 4 instead of the 6 weeks. Because when we schedule on the 4th week, we are sure on that we are on the proliferative phase still, and we can take advantage on that to use the regulatory effect of the PDL to maintain and to guide the final part of that phase. Next slide. On the next appointment, if we schedule on 4 weeks, we still should use the PDL1 suprapuric dosing. And on this stage, as we are on the transition to the proliferative phase, now that it's important to use an ablative or non-ablative fractional laser to induce the heat shock proteins release to regulate the collagen deposition. In this case, we should use an ablative fractional laser with moderate density and moderate energy, or a non-ablative fractional laser instead, with all the aftercare that we already discussed. Next appointments should be done on a 6-week basis, and we should treat the scar till no further improvement noticed on the scar progression. Next slide, please. On an atrophic scar, if red and less than 6 months old, although this is not an exclusionary factor, the age of the scar, we should pass to a purpuric dosing, shortening the pulse and increasing the fluence. And the main treatment of the atrophic scarring is the ablative fractional laser using a moderate density with moderate energy. Here, the treatments should be done on a 6-week basis. Next slide. On the hypertrophic scarring, as we have a more dense tissue, we should use still purpuric dosing, but we have to increase the fluence to get the same kind of response. And sometimes we have to stack two pulses on these scars, because sometimes with the fibrosis, it's more difficult to induce this purpuric response. We should combine always with the ablative fractional laser with low density, but with high energy to get on more deep on the scar, and do the laser drug delivery just afterwards with triamcinolone load acetonide. Here, the compression is mandatory because we know that compression modulates the response of the myofibroblasts, and the treatments are still on the 6-week basis intervals. Next slide, please. So let's combine this all together to get an easy access info all together. Next slide, please. And basically, arranging and organizing this by boxes and by devices. When we have a newly formed scar, we can use a V-beam with this kind of settings. And if we don't have a V-beam, but we have a short banded IPL-like ellipse, we can also induce this kind of response with purpura, with a short pulse, and consider using an ablative or non-ablative fractional laser if we have previous abnormal scarring history. If we have an atrophic or hypertrophic scar, we should always start with the vascular laser on purpuric dosing. And the ablative laser should be used on a moderate density and moderate energy on the atrophic scars, and with a low density and high energy combined with laser drug delivery on the hypertrophic scarring. Next slide. Just finishing with a few more important points. Please do not forget that it's never too late to initiate a scar treatment, even if the scar is already maturated nodes. In higher phototypes or in post-inflammatory hyperpigmentation prone skin, we should consider to reduce the energy and density of an ablative fractional laser, or consider a non-ablative fractional laser. On an hyperpigmented scar, we can associate a picosecond laser to induce a normalization of the pigmentation, but we should also have in mind that our fractional lasers and even the vascular laser as a competing chromophore with melanin and the thermal laser will injure the melanocytes too. So even with the other treatment without the picosecond laser, we are already treating the hyperpigmentation. On hypopigmented scars, the mainstay of treatment is mainly the ablative fractional laser, and we can help the ablative fractional laser with some topicals like the metoprolol or tacrolimus. And nowadays we have some evidence that fractional picosecond laser can be useful on atrophic scarring, having already some papers that compares with non-ablative fractional laser with the same results. And the bottom line is never to forget the basics, namely the hydration, the compression, and the sun blocking. Next slide. So I'll pass the word to Didak that will proceed with the laser techniques for acne scarring.
Thank you very much, Pedro. Thanks everyone for joining us in this webinar, and thank you to Candela for inviting me to do this speech. So Pedro has talked to you about traumatic scars, and we're now going to head to atrophic scarring, in this case, acne scar, right? So this speech is going to be quite short, and what is the menu? Treating volume defects, and after that we're going to target color and also slide volume defects. So for acne scarring, and in general terms for scars, we normally need different approaches and techniques to treat them, but in this speech we're just going to give some capsules regarding lasers. So we're just going to talk about lasers, and we're not going to talk about any other techniques, all right? So the first step is addressing volume, in this case, atrophy. I just want to share with you this 3 steps approach with the laser treating acne scarring. So the first step, and it is the most important one, is recognizing what type of acne scarring you're in front of. Right, so the first step is recognizing. The second one is selecting the device or the wavelengths which is more appropriate to treat this scarring. And the third one is setting up this device. Okay, so first one is recognizing, second one is selecting the device, and then setting up the parameters. So in recognizing acne scars, in general terms, as a summary, we have to take into account these 2 aspects, right? We have to think about cheese. If we see a wavy surface, just like cream cheese, we are in front of rolling scarring, okay? If we see sharply etched pits, we are in front of box scar and or ice pick scar, all right? So just think about cheese. We see here examples of rolling scarring. You see that the surface is wavy. We don't have clear-cut edges of this scarring. And this is the opposite aspect, right? We do have very sharply delineated edges in these scars, right? So in the first example, we had rolling scarring, and here we do have ice pick and boxcar scarring, okay? We also have very sharply demarcated margins here. So we're talking about boxcar scarring in ice picks. Same here. Same here too. Sharply demarcated margins. Same here. Okay, so in general terms, we do have these two types of scars regarding acne scarring, right? So if we see rolling scarring, a wavy surface, we have to think that this scarring do have deep fibrosis. So the target of the treatment, what we have to take into account is that we have to reach deep dermis. So for that, we're going to use the CO2 fractional laser in deep mode to reach papillary and reticular dermis. On the other side, if we do have boxcar and or ice pick scarring, we have to go superficial and deep. We have to go superficial because we want to improve these edges of the scars, right? And we also have to go deep because we want to make the skin produce collagen. So we have to treat both depths in the skin, right? If we have a few and big scarring, we're going to use the core system in its classic resurfacing mode, and after that in its fractional deep mode. So we can reach both depths simultaneously, okay? On the other side, if we have many ice pick or boxcar scarring and they are very small and widespread, we're going to do a general treatment with fractional fusion mode, because with the ring of the fusion mode, we're going to treat the superficial scarring, and with the core of the fusion mode, we're going to treat the deep scarring of it, okay? So this is a general algorithm to treat acne scarring with a core system. So for example, if this is a real patient, we see a sharply demarcated boxcar and ice pick scarring here. So what I would do is first do a pass of a full resurfacing mode, destroying the walls and the floor of these scars. After that, so I'm being superficial here, and after that, I'm going to do a general pass here with a deep or fusion mode, and on top of it, in a more general way, a more general fashion, I'm going to swipe all the area with the Frax 1550, right? So this is a general advice to treat acne scarring with these two systems, okay? The first step of this algorithm is setting the parameters. You know that parameters are different using different systems, so these ones are just useful for core and for the normals, right? So if I would like to use the deep mode with the core, I want to go deep, as the name says, and I'm going to address it with high energy. So most of the times I use 70 millijoules, right? The most important setting regarding secondary effects is laser beam density, right? So if you use low density, just like 5%, which is the maximum that the deep mode allows us to use, you're going to be safe. You would not be safe if you would use 70 millijoules with a 25% density, for example. So that's why the system itself blocks the maximum density to 5%, because you're going to be safe, although you're using high energy, okay? So these are the settings I normally use with the deep mode when I want to reach deep dermis. For each and every one of the ice pick and boxcar scarring, I use the classic resurfacing mode with a spot size of 2 or 3 millimeters, depending on the diameter of each scar. I use the circle shape, and I normally use between 2 and 3 millijoules energy. You can, of course, do some stacking if that concrete scar is very deep, and I tend to use 0.5 repetition sequence. If I would like to use the fusion mode, so I can simultaneously treat superficial and deep dermis, that's the settings I would use. I tend to use the hexagon shape, maximum size, 9 millimeters. The density I tend to use is 25. It's something in between. It's not that high. And with the core, which is the deep mode, I use normally 70 millijoules. And with the ring, I tend to use 50 millijoules. So with that, I'm treating both depths of the skin, okay? So this is exactly the end point after a treatment of acne scarring. You see the complete destruction of the walls and the floor of each of the boxcar and ice pick scarring. And after that, I made a general pass of the deep mode. Okay, so this is the end point we're looking for. This is a before and after case. After 2 sessions spared 6 months in between, using the techniques I told you about. You see that box scar, scarring here, the mainly ones that improve. Okay, so that was the first approach. We were talking about big atrophy, big defect in volume, and now we're going to switch to treat color and mild atrophy in acne scarring. And now we're going to use a different energy-based device, which is the Nordless, all right? We're also going to use the same algorithm, recognize what kind of scars I'm treating, then selecting what kind of device I'm going to use, and then setting up its parameters, okay? So this would be a acne scarring, mild acne scarring, right? We still have some redness, we still have some pigmentation, which are these arrows, and we also have slight volume defects. We see some boxcar scarring, we see here some ice pick scarring, but please note that they are very superficial. All right, so the main targets or chromophores here are the redness and the water, because I want to treat slight volume changes, okay? So with this kind of semiology, I'm going to use a different device, which is not the core, but the Nordless, okay? So for erythema, I'm going to use the intense pulse light, and because I want to address the red, and I want to be superficial in this case, I'm going to select the PR 530 handpiece, right? That's a special made to treat red targets. And for slight volume changes, I'm going to use the Nordless, but with a Frax handpiece. Okay, so I'm going to combine both handpieces in the same session, so I can address red, and after that I can address slight volume changes. All right, setting up the parameters of the device. So in terms of redness, I'm going to use the PR handpiece, and I can use 2 types of energy here, right? Or 2 types of settings. If I want to be aggressive and if I want to use it more like a PDL system, sorry, I'm going to shorten the duration pulse, and I'm going to move between 0.5 and 1.5 milliseconds, and with this energy you're seeing here. If I want to be less aggressive and I don't want to cause any purpura, I may making longer duration of pulse, and I'm going to switch to 6 milliseconds with this energy you're seeing here. Okay, so I can use both depending on what the patient wants and what we see when we explore the patient, okay? All right, and these are the settings of the Frax. So I normally move between 3.5 and 4.5 milliseconds duration pulse, and the energy is something in between 50 and 60 millijoules. All right, I normally tend to leave the same density advised by the machine, which is 25, and I tend to do 3 or maybe 4 passes. All right, so as a summary, what is the advantage of using this algorithm? The idea is using the most effective treatment, which is the full beam or classic CO2 laser, for the worst scars. So I'm just limiting the best device and technique I have in very small areas. So I'm taking the best profit of it, but because I'm not using it in a wide fashion, I'm not going to have many secondary effects as you could expect if you use it widely. All right, so I'm just limiting my aggressiveness to where I really need it, okay? So if I tend to use other settings that are lower, or I tend to use other devices that are safer in a wider manner, I'm going to gain in terms of safety, and I'm going to keep the less efficient systems for the areas that are not that bad. Okay, so just limiting aggressiveness is the main good point of this technique, right? But not everything is good with this technique because it takes some time to learn and some time to get some practice with it and get to know which settings to use. All right. And there is an important point that you should make the patient notice, and is that if you destroy the walls and the floor of each and every one of the scars, for some weeks, these scars are going to look worse because they will look wider, deeper, and redder, right? So it's absolutely normal that for some weeks, box scar and ice pick scars, are going to look worse, right? You can expect it. Don't worry, tell the patient before the treatment, okay? Of course, it is a time-consuming procedure for the doctor because you're going to use 3 different types of lasers in the same session, so it takes some time to do it, right? But believe me when I say it's worth doing. All right, so once we finish the webinar, we'll have some time for the Q&A. Now I'm going to give the word to Pedro again. I'm just going to select the other presentation, which is clinical cases 1, right? Okay, we're back, and now Pedro is going to show us some of his cases. All right, Pedro?
Thanks, Didac. So let's proceed and let's try to do this on an interactive fashion to be more productive to everyone. I will not show you befores and afters, but I would like to revise with you the clinical judgment and the treatment plan setup for you to be comfortable of doing that when you're treating your scars. Next slide, please. So I will ask you some questions that I would love you to answer on the chat box. You should select send to all participants on the drop-down box and send your answers there for us to discuss them. So here we have an 42 years old female with a previous C-sec scar done 4 years ago that is fine. It's just linear. This scar that we see on the picture is 2 weeks post-op, and she's on the appointment to remove the sutures. So, what would you do to this scar? Please answer me on your chat box, and we'll wait few seconds for you to write it down. Next slide, please, Didac. So, as we already discussed, this is a case to perform laser-assisted wound healing. And on the our first intention on treating this is to modulate the inflammatory and the proliferative phase. This is done mainly with a vascular laser, and in this case, using an V-beam, we should use a superpuric dose. On this case, I would use like 4.0 to 4.5 joules per square centimeter of fluids. And after that, for home care, I would prescribe an interactive silicone gel dressing and broad spectrum sun protection factor. Next questions. When should I, and thinking that we are seeing this patient just 2 weeks post-op, when should we set the next appointment and what to do on next appointment? Please answer me on your chat box. So this time interval is for the next session of treatment. And what to do on this appointment. Next slide, please, Didac. So as we are just on the transition at 2 weeks, thinking about the first appointment, we are on the transition from the inflammatory to the proliferative phase. It could be better to do a short appointment on 4 weeks to still treat the end of the proliferative phase, and if as we are treating the proliferative and transition to remodeling phase, we can repeat the PDL with the same dosage to limit the collagen overgrowth. And on this case, we can actually add a non-ablative fractional laser on a moderate to high energy and with moderate to high density. And after this session, we will shift to a 6-week interval appointments, now leading or using the other guidelines to treat as an hypertrophic or atrophic scar. Next slide and next case, please. So on our case 2, we have a 24-year-old healthy male with no previous scars that has these scars 2 years after a shoulder arthroscopy. So what would you do to these scars? Next slide, please, Didak. So if we focus on this scar's property, it's not easy to diagnose on terms of texture because we have some kind of hypertrophy on the upper scar and the bottom one is clearly atrophic. So we should start here to minimize the vascular activity on the scar using a PDL with a purpuric dosing. And just afterwards, use an ablative fractional laser with moderate density and moderate energy using our core. For instance, I would use like 70 millijoules with 4% density double pass to increase this density to 8% on the upper scar. And on the lower one, as is more atrophic than the upper one, I would use 60 millijoules with a double pass too. In the upper one, as we have this like fibrotic activity, we can consider laser drug delivery with topical botulinum toxin. And we can also consider, as we have this fibrotic hyper response, let us say, a silicone sheeting mainly on the upper scars. On this treatment, use a 6-week interval between each session. Next slide, please. Per case. So we have a female, 30 years old and healthy with no previous scars. And she has this scar on her lower limb with 5 years evolution after a surgical reduction of a femoral fracture. So what would you do on this scar? Please answer on the chat window rather than in the Q&A. That is easier for us to see. Thank you. Didak, next slide, please. So the mainstay of treatment of atrophic scars is the ablative fractional laser. As we can see here in vascular activity, we don't have to use a vascular laser, so we are going straight forward to ablative fractional one. With our core, I would use probably a 60 millijoules with a double pass with 4% density, and afterwards hydration and some kind of compression with a silicone-based gel. And even as it is under the clothing, I always prescribe the sunblock because we have always some radiation that can penetrate through the clothing. And we are still on the 6-week interval treatments. Next case, Didak, please. So, last case for me, a 30-year-old healthy female with no previous scarring and has this 8 years post-op of a C-section. So, how would you treat this scar? Next slide, Didak, please. First of all, we have to assess properly this scar. We have like a half scar that is hypertrophic and other half that is atrophic. And this will lead us to treat these two separate parts on a different way. So in the atrophic part, that is our right one on the right side of the picture, we'll use a vascular laser with a purpuric dosing, but with medium-high fluencies, and afterwards a fractional laser with moderate density and moderate energy. We're talking about 60 to 70 millijoules double plus of 4% density, and on the hypertrophic part, we should raise the fluence on the vascular laser, and on the fractional laser, we should lower the energy, but lower the density, sorry, and rise energy and consider triamcinolone laser drug delivery on the hypertrophic part. We should also consider the silicone sheeting here, and again, our interval on treatments are on the 6 weeks based. Next slide. And that's it for me.
All right, thank you very much, Pedro, for your cases. Now we're going to move forward for some more clinical cases regarding acne scarring. So the first one is a phototype 4 patient with severe ice-pick box scar and hypertrophic acne scarring. We're going to use the core system with these settings that we have talked about before. And now we're going to see the video of the procedure so you can see it from a practical point of view. There we go. So you see here that we have sharply edged scars. So we are talking about using the classic resurfacing mode. There we go. And we are actually shooting at each and every one of the scars. We're using here the 3mm spot, 3 millijoules fluence. I'm just destroying every wall and all the floors of these small scars, right? You will see when I finish the procedure that the end point of this stage of the treatment is very similar to that we obtain with the TCA used in cross fashion, right? So you will see it when we finish that. I'm just going to move a little bit forward. All right, so this is the end point after the full resurfacing in a limited fashion with the core system, all right? It really reminds us of the TCA cross technique. And after that, we're going to move forward with the deep mode, 5% density, 70 millijoules, right? And we're using it in a wider fashion. I can pass all over the area, including scars I have treated before. Okay, I'm using cold air here for the pain. For this procedure, the patient has been under a numbing cream for about 30-45 minutes. Then we remove it, and then we proceed. All right, so once we have treated all of the areas, I'm going to show you a little trick with how to finish the procedure. I'm going to move forward. All right, this patient also had a keloid or hypertrophic scarring in the middle of on top of the nose. I tried to inject some steroid with different needles, but it was like stone. So I was not able to do that. I wasn't able to inject anything here inside. So as you will see, I finally moved to the laser assisted drug delivery with a deep mode. So I also shoot it here with a deep mode. And after that, I just applied triamcinolone acetonide on top of it. All right. So we've seen 3 different techniques in the same patient. This is the final endpoint. That's a perfect endpoint. Slight erythema, big edema, oozing, and pinpoint bleeding. That's exactly what we want after treating acne scars with the core. All right. We'll move forward to the next video. There we go. This is case number 2, severe rolling acne scars. Same settings or very similar to the ones we talked about. This is another video, and here this is the video which I'm going to show you the trick on how to finish the resurfacing with the core. All right, so first in the worst areas, I'm doing the full resurfacing mode. In this case, it's 3 millijoules and 5 millimeters. After that, general pass with a deep mode, 75 joules in this case, because we're treating a thick skin and we want to reach deep dermis. Okay, so we're doing a general pass. All right, this is the end point that we want to: oozing, pinpoint bleeding, erythema, edema. And here's the trick. All right, I'm just using the mid mode because I want to. There we go. We'll stop. Because I want to do a transition between the treated area and the non-treated area. So I'm just doing a gradation in between that. So you will not notice the difference between the treated and non-treated area. So this is a small trick. You can do it with the mid mode, or you can keep on using the deep mode, but just moving constantly, the handpiece. Okay. So this is the endpoint. We'll also see a final image of the endpoint. There we go. That's it. Right, that's exactly what we want after a core resurfacing for acne scar. Right, that's a completely normal endpoint. Okay. So next case, and this is the last one, is photo aging and rolling acne scars in a girl. We're going to use these devices with these hand pieces and with these settings we're seeing here. All right, we're going to actually use 3 systems. So this is the first pass with the IPL, right? This is the VL555 handpiece. I want to address here the pigmentation and also a little bit of redness. I tend to use just one single pulse. So with this pulse duration and with this energy, I can simultaneously reach red and brown, right? So with just one single pass and without changing the handpiece, I can do all the job in just in a row. Right, so here's the first pass of the IPL. You see the endpoint here. Lenticels and epithelials are turning darker. That's exactly what we want. The areas that do not have any skin lesions, do not react, so they're perfectly pink, right? And you see that the changes only occur where we want to. Right, we're being very selective. That's what lasers and IPL are for, right? So this is the perfect endpoint of an IPL pass. Okay, so sorry, I'm going to move. I'm sorry, forward if I can go back. There we go. All right, this is the second pass. I'm using here the Frax 1550. We're moving between 3.5 and 4 milliseconds and 50 millijoules approximately. I did the whole face except for the forehead. In the forehead, she had fibrotic scars, which are this white you see here. And for these more severe scars, I use the core system. Okay, so once again, I'm limiting the most aggressive treatment for the more damaged areas. And if I want to be more gentle, then I use the IPL or the Frax, right? So we have used 3 different devices in the same patient, in the same session, so we can address each and every one of the aspects of her problems with just one session, okay? So I'm going to show you just some before and after pictures using these techniques, no videos at all. Ice pick and boxcar scarring. This is the baseline picture. This is going to be 2 sessions after with the core using exactly the same settings I told you. All right, so full resurfacing on the center of each scar, and after that, fusion or deep mode on top of it. This is the other side. This is before. This is after. Huge improvement. once you do CO2 laser to treat acne scarring, you have to wait up until a year or a year and a half to see the complete result, right? There are some studies that say that you keep on producing collagen even a year and a half after the CO2 laser session, all right? So during the first weeks, this patient is going to be probably worse because these scars are going to be redder, wider, and deeper. That's completely normal. And with months and within 1 year, it's going to improve. Okay. So this is one before and after. This is a complete full resurfacing. That's before and after. I know the light is slightly different, but you know the improvement is something you can notice. And that's all. Okay, so I guess we should open now the question and answer time. And Pedro and I are here just to answer all your questions.
So I think I'll start. I have here 3 questions to address. So the first one is what about the 1064 instead of the pulsatile laser? So first of all, let me just say that the laser that has the highest quantity and quality of evidence on treating the vascular part of scars is the pulsatile laser. Yes, we can use any vascular laser, but with the 1064, we should use normally with very short pulses on the microsecond range, normally 300 to 500 microsecond with a 6mm spot and fluences that will be in 55 to 60 joules. We should see this superpuric response too, but beware that we have much heat diffusion and sometimes this could lead to complications. So it's preferable to use like an IPL and PDL or a PDL rather than 1064. So next question.
I have a question for me, Pedro. Dr. Adrián Alegre says if we normally use platelet-rich plasma for treating scars, I'm going to answer that regarding scarring. There are just a couple of studies that say that, and they are split phase case series, right? And they find better results, right? The epithelialization is faster and the final result is better. But my question is whether the cost benefit ratio is also positive for that. I mean, I'm not sure that the percentage of improvement that we see when we use PRP is worth enough to pay the cost of it. So I normally tend not to use it, but of course you can do it. And there are some studies which are not very potent, but they support it. So it's a good thing to do. You can do it.
Let me just add something on that and on general scarring. I normally don't use it too. Just as you explained to us, Didak, I don't find the cost benefit worth it. There are some papers now and some trials going on of using, for example, biostimulators as calcium hydroxyapatite and hyperdiluted, obviously, and PLA for drug delivery on atrophic scarring, and with good preliminary results, but with inconsistent data for now. That could be another option on the future. So moving on to the next question, what about planning laser treatments when using absorbable sutures? The main issue with absorbable sutures is the colored ones, because if you use a vascular laser with an colored suture, we will have chromophore interaction. So with colorless sutures, they can be initiated as the same way with the normal or non-absorbable sutures, meaning that on the predictable suture removal day, we can start laser treatment on that day. Sorry. For instance, if using a colored suture, we have to know the depth of that suture. If it's deep enough, you can use more superficial wavelengths as the 595 and use it equal as the suture wasn't there. If they are superficial, we can't address it with vascular lasers and use only or the ablative fractional or the non-ablative fractional laser. I'll pass to you, Didac. Don't know if you...
There is another question. Do you use depigmentation substances after CO2 treatment in order to prevent possible hyperpigmentation? Yes, definitely. I use it before and after the treatment. So 1 month before and 1 month after the treatment, they use hydroquinone. All right. There is another question regarding, where was it? What are the main complications you can find with these tribal techniques? Well, actually, the idea of these techniques is reducing complications, right? So probably you can expect less complications than using each and every one of the systems separately with higher energies or in a wider manner, right? So in terms of complications, so what you would find are the same ones, but you're limiting the areas of application, so you're going to find less complications than using them in a traditional manner, right? But of course, you can experience, persistent erythema, you can have infection of the scabs, you may have scarring, right? So the complications are the same, but you have less probability to get them with the tribal technique. Do you have any other question for you, Pedro?
I think I have a couple more. On the treatment of keloids, when programmed for surgical, if we inject the 3-hexanoyl acetonide at the day of the suture removal, or we wait to the keloid to come up more evident. The treatment of keloids on this kind of treatment regimen is mainly the prevention. The cosmetic result will always be better if we prevent it rather than we treat it when it appears. So for me, on the day of suture, is imperative to use an vascular laser to regulate that cytokine media that is going on the scar healing process. I use directly an ablative fractional laser with low density but high energy, and yes, I do not inject, but I do laser drug delivery with triamcinolone acetonide. On this case, as the scar is not formed yet, I lower the concentration from 10 milligrams to 5 or less. It depends on the risk on the area. And I assess the tension of the scar. Mainly if we are treating on the pre-sternal surface, we should consider to add botulinum toxin on that area to reduce the tension associated to the scar.
All right, there is another question here regarding keloid scarring. Would you use PDL combined with triamcinolone in the same session? If I would have to ask, the answer is yes. There is actually one webinar we did for Candela 2 where we explained some algorithms for keloid and with some videos. And yes, in the same session, we actually use PDL or IPL plus cryotherapy plus intralesional drugs. So the answer in my case is yes. So the more techniques you can use in the same session, the more effectiveness you're going to gain most of the times. You agree, Pedro?
Yeah, totally agree. But when we are combining techniques and procedures, we have always to think about what are we adding on each step, because when we are combining these treatments, we should think about how synergistic they will be on this physiopathological mechanism. Because if we have a complication and we don't think on these steps on and how these all steps are interacting, we can lose the control of that healing process and have some complications and scar aggravation instead of an improvement that we are seeking for. So yes, we should combine, but meaningfully.
Completely agree, and I just wanted to add something. If you're combining different techniques in the same session, you have to take into account the order of the sequence. I mean, for example, if I inject an aqueous solution first, then I'm not going to pass with a non-ablative fractional laser because its chromophore is water, right? And I could burn the patient. So the order of the sequence is also very important when treating, when using different techniques in the same session, right? So the end point of the previous technique should not be a target for the next technique I'm going to use in the sequence. Okay, so that's very important too. There is another question regarding what is your protocol when using 5FU? We do have 5FU in Spain. It is off-label. If I'm not wrong, it's actually off-label worldwide. But there is much evidence that 5FU is becoming more and more popular because of its efficacy in hypertrophic and keloid scarring. Actually, in the current knowledge, the drugs of choice when using intralesional drugs is a mixture of 9 parts of 5FU and 1 part of triamcinolone acetonide. Right? The concentration of 5FU is universal and it's 15 milligrams milliliters. And depending on the country, you will have different triamcinolone acetonide concentrations. We here in Spain use 40 milligrams milliliters, right? So with that, it would be 1 part of triamcinolone acetonide and 9 parts 5FU. So this solution is said to be the safest one and the most efficient one. It's actually more efficient and has less side effects than using 5FU or TAC all alone. All right, so That would be my advice. Do you have any other question to answer, Pedro?
Yeah, just one, I think. That is how we adjust parameters to hypertrophic scars in skin type 4, 5, or 6. Well, on these phototypes, we have to do some changes on the two regimens, either on the vascular and on the water-based lasers. On the vascular ones, obviously on phototypes 5 and 6, the PDL is not indicated. We can use in some light force non-tanned ones with larger pulse durations and lower fluencies. But on these skin phototypes, the only option that we have is using or a 5 millisecond Nd:YAG or a sub-millisecond regimen Nd:YAG. On the ablative fractional lasers, we should lower the energy, but mainly lower the density, because it's the density that will lead us, mainly density that will lead us to complications on these skin phototypes.
Okay, we don't have more time for the Q&A time, but anyway, you can send us email or you can contact Candela. And also, if you're interested in any other specific webinars, you can, of course, give this message or this suggestion to Candela staff, right? So thank you very much to all of you. Thank you very much, Pedro, for your lovely presentation. And once again, thank you to Candela for inviting us here. So we're here to serve you, and anything you need from us, we will be delighted to answer you.
Thank you, Dr. Marco. Thank you, Dr. Santos. It was very interesting. I hope all the attendants like the webinar, and we look forward to meeting you again in our next webinar. Thank you.